From the JAMA Network, this is JAMA Neurology Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Neurology.
My name is Dr. Cynthia Armand, Associate Professor of Neurology at Albert Einstein College of Medicine, Montefiore Medical Center, and JAMA Neurology Web Editor. Today, I have with me Dr. Zhongrong Miao, who is here to discuss his work entitled Alberta Stroke Program Early Computed Tomography Score, Infarct Core Volume, and Endovascular Therapy Outcomes in Patients with Large Infarct. Dr. Miao is an interventional radiologist at Beijing Tiantan Hospital, Capital Medical University in Beijing, China. Dr. Miao, welcome to the podcast.
Thank you very much. I'm very honored to be invited.
I am very excited to talk about this topic with you. Your work is a secondary analysis, correct?
Yes, it's a secondary analysis of angel aspect trial.
Can you tell us about the angel aspect trial?
Yes, it's a trial of large vascular occlusion of anterior circulation within 24 hours for patients with a large infarct core that is defined as aspects score 3 to 5 or infarct volume 70 to 100. We want to treat this kind of patients that previously have no evidence, and we hope to compare whether endovascular treatment plus medical management is better than best medical management alone.
Yes, and for our listeners, the angel aspect score is the endovascular therapy in acute anterior circulation large vessel occlusive patients with a large infarct core. And so that's the study that we are discussing. And I think for me, the significance is basically what happens to these patients who have a large infarct core volume. We know that time is brain, and a small infarct core volume leads to better outcomes. We've seen that. But the question is, what happens in these patients that already have this large core infarct volume?
And previously, when we don't have endovascular treatment, this kind of patients really has very bad outcome. Even though we have a guideline to treat acute large vascular occlusion, but for the previous positive RCTs, most of them are small infarct core. In clinical practice, we don't know whether patients with large core is better or not. Some of them, even though we recanalized, they have hemorrhage and no good result. So we need to have a trial to test.
Right. Yes, I think that's great because even with endovascular treatment, that's the question, right? These patients are candidates based off of the core volume. So we want to make sure that the reperfusion injury that could potentially occur is less likely to happen, correct?
Yeah, previously, even though we have recanalized the patients, some of them hemorrhage, and we don't know whether to do this is right or wrong. So we start this trial and design this trial.
Now, can you tell our listeners about specifically what the aspect score is, and then we will go into your work?
Yes, aspect score is a kind of score used to test whether the CT scan have a large volume infarcted. So we use this kind of score is from 0 to 10 to different area of our brain. If the score is very high, for example 10, that means we have no infarct area in the brain. If it is 0, that means most of this area is affected and lost the ability. So the lower the aspect score is, the more infarct volume the patient have, and the worse result the patient is even after treatment.
And this is mainly looking at radiographical correspondence, correct? They're looking at an image to look at the core volume and calculating that in order to determine whether or not to proceed with different interventions.
Yes, previously this SPECT score is used for intravenous thrombolysis. For higher score, they have good result. For lower score, they have bad result. But after we use it during endovascular treatment, we have the same result. So we commonly use this kind of score to test whether the patient is suitable for endovascular treatment with a large vascular occlusion in many trials.
Now, let's talk about the trial that you performed with you and your colleagues.
Yeah, this trial started in 2020, and about 46 centers joined in this trial and around China, and we enrolled about 456 patients during these years. But this trial, after two interim analysis, it stopped early because the endovascular treatment showed significant better result and medical management alone.
Right. So tell us about the methods and what the cohorts were who were enrolled, just so we have a baseline, because I know it is a secondary analysis.
For this subgroup analysis, we aimed at for the angiospastic trials enrolled patients. We have three kinds of patients enrolled in angiospastic trial. First, all the patients with a SPECT score 3 to 5. The other is for patients with a SPECT score of 0 to 2, but have the volume of 70 to 100 milliliter. We also enrolled. We have another kind of patients that is a SPECT score more than 6, but beyond 6 hours with a volume of Infarct 70 to 100. After we finished the angiospastic trial, we found we only enrolled patients with a SPECT score 3 to 5 and patients with a SPECT score 0 to 2 with the Infarct volume of 70 to 100 millimeter. So we think there's a mismatch between a SPECT score and the Infarct per volume. We need to find which kind of patient can have the best result after we compare the different kind of mismatch. So I think it's quite different from before. We think a SPECT 3 to 5, all these kind of patients have Infarct volume of 70 to 100. There are some mismatch between a SPECT score and the Infarct volume. So we separated the patients for this subgroup analysis into a SPECT score 3 to 5 with the core volume of 70 to 100. And another group is a SPECT 3 to 5 with the Infarct volume for more than 20 milliliter. And the last group is a SPECT 0 to 2 with the Infarct volume between 70 to 100 milliliter, and compare these three group kind of patients, which will have the best result and the safety and the efficacy of different mismatch between aspects and the Infarct volume. That is what we separate for patients and compare these three groups.
I see. So essentially what we have are these three groups. We have the one group with the low aspect score of 0 to 2, and then we have two groups with aspect scores of 3 to 5, but with varying infarct volume, one with less than 70 milliliters and one with greater than 70 milliliters. And each of those groups were compared in terms of endovascular treatment versus medical management. Now, tell us about our results.
The result is that the generalized odds ratio for the shift in the 90-day MRS distribution towards better outcomes with EVT versus medical management in patients with a SPECT 3 to 5 and low infarct volume for less than 70 is significant. But patients with a SPECT 3 to 5 with infarct volume of 70 millimeter or greater, there's no different significance of MRS distribution. For the last group, there also no significance. So in this study, no significant interaction was found between baseline imaging status, but we found that for the aspect score 3 to 5 with a lower infarct volume, they seem to have a better result than the other two groups. That is the conclusion we could give.
Dr. Miao, the MRS score that you used in the trial in order to assess better outcomes, can you explain to our listeners what exactly that means?
Yes, MRI score is modified ranking score. It's commonly used to evaluate whether patients have a good result after the treatment. We use this score for 90 days follow-up. For this score, it is 0 to 6. So if it is lower, that means better. For 0, the patient has no effect by the stroke, and for 6 is death. So the higher means the worse the result is. That is the MRI score we commonly used.
We're seeing that, again, the aspect score, a better aspect score, and the low volume involvement of infarct really tends to have better results, better outcomes for endovascular treatment. What would you say about this result and what it means for current practice in terms of the lower aspect scores and what we usually do? And what do you think is needed to push the needle for us to get better outcomes for patients who may be farther along? I think that's a lot to ask, but what do you think is needed?
Yeah, I think after we have a lot of large infarct RST studies and have the positive result, many of the doctors like to treat this kind of patient. But this doesn't mean the volume is not important. We couldn't only use a SPECT score to evaluate patients. We also need the volume and the perfusion to decide which kind of patient is better between a SPECT score 3 to 5 and choose this kind of patient to treat. They will have a better outcome.
Dr. Miao, I know you have plenty of research in this arena. What do you think is next in this particular topic in finding and searching for better outcomes for our stroke patients?
Yes, and in this area, I think not only endovascular treatment alone, even though we treat low SPECT score patients, not significant patients have better outcome. We could only improve some of them. We need to focus on how to increase the functional independence. So the next step, maybe we could focusing on the treatment of surgery, whether we need quick surgery after endovascular treatment, or focusing on better ways to decrease the hemorrhage rate, because endovascular treatment will increase the hemorrhage even though we have the recurrent vascular. And also another field is just like the stem cell and other drugs to protect neuron. That will give us better outcomes after we recanalize the patients with low SPECT score or with large infarct core volume. So I think that is other parts very important for this kind of patients.
Dr. Miao, thank you so much for joining us today on the podcast.
Thank you very much for inviting me, and I'm very happy to discuss with you. Thanks for all the angiospectral investigators. And for this subgroup analysis, Dr. Dapeng Sun and Dr. Xiaochuan Huo did a lot of field and analysis in this paper, and thanks for them.
Thank you so much. This episode was produced by Shelley Steffens at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. This is Dr. Cynthia Armand. Thank you for listening.